When it comes to treating prostate cancer, it's an exciting time for patients, but a confusing time for physicians. Dr. Walter Stadler of University of Chicago explains.
On this year's conference, at least in regards to prostate cancer, there is not that much exciting new things per se, but there is a realization, I should state, of a number of new therapies that are now coming to the forefront for prostate cancer, and an increasing realization that this is going to make the treatment of our prostate cancer patients somewhat more complex. There are a number of new treatment modalities that have been developed. There are new androgen receptor pathway blockers. There are new chemotherapy agents, and there's a new set of bone-directed agents that all of which have either been approved or in late stages of approval. With a number of these new agents, and assuming that many of the promising ones are also going to become approved for this disease, a major question then becomes, what order does one use these agents? Should they be used in combination? And if one talks about agents that are very similar, for example, in the androgen receptor pathway, is one drug better than another? The short answer right now is we don't know. Traditionally, the urology community has administered some of the local therapies, certainly the surgery for prostate cancer, and has done much of the initial hormonal therapy for these patients. And the medical oncology community has performed many of the chemotherapy regimens. What's happening is that now with increasing options for hormonal or androgen receptor pathway directed therapy, some of which are now oral medications such as abiraterone, the division of labor, as I might put it, is becoming a little bit more confused, and it's not clear who should be doing what. As always, from a patient perspective, the best way to solve the problem is to have the different specialties work together as closely as possible and to give a unified message to the patient. From a patient perspective, he doesn't care who administers, he just wants to make sure that the physician who is doing the treatment understands how to provide that treatment in the best manner possible. The important message for family physicians and the primary care community is that prostate cancer, and even metastatic prostate cancer, has become a serious chronic disease that requires treatment with a number of different medications over time, and in that manner is probably not much different than serious cardiac disease. In that sense, I think it's important for the primary care community to recognize that they will need to partner with the specialists who are conducting this care and often don't have an understanding of the patient's other chronic medical problems that the primary care physician needs to provide. This is an exciting time for patients. I think that it's a time for prostate cancer patients where we can provide an increasing number of treatments that can serve to improve not only the length but also the quality of life.